Again, recording in progress. So my name is Paul Pepe, and I'm welcoming you all to the latest gathering of the Eagles, so the jurisdictional medical directors for some of our largest cities across the United States, plus so many of their other counterparts in other areas. And again, this is tape recorded and going out to the rest of the world. So keep that in mind as we go through this today. I'm not sure what happened. We have a pretty small gathering today, which is kind of good because we can get through and I can talk to everybody and hopefully get everybody a chance to talk, which will be really kind. Yes.
My invitations all disappeared.
They did.
When that thing happened with Julian, they did not repopulate.
Oh.
And I didn't notice it until today, but all of my invitations are gone off my computers.
Okay. So can you tell us a little bit what that's about, or Julian?
Yeah. So when we very first started these meetings 2 years ago, I created the invitation through Outlook with my previous employer email account. Obviously, back in October, I left that employer and where I'm at now. And it seems like the IT department of that employer finally closed my email accounts, which automatically canceled all of those invites and recurring invites. So I can work right now to resend the invite under a non-employer email account that won't expire. And then that should get everyone back on track. It'll also have, of course, the latest Zoom link and everything, because those emails still have the old Zoom link anyways. So that's where we're at.
Okay, got it. So that's interesting then. Jim, anything else to add to that though then? But,
no, it didn't come up, Paul. I'm sorry I did. And you and Julian, I should have noticed this earlier. But that's what happened in my world. I apologize.
Okay. So first of all, before then I get going, I want to see there's some people that probably have some time constraints. Please let me know who they are. Candace, how are you doing for time? Because I really need to talk to you. So how are you?
I've got time today. Looking forward to meeting with you after, and I'll be on today for anything you need. I can also send out the invite, Julian, if that helps, since we do the CME anyway, whatever you guys prefer.
Yeah, no, I think that would be helpful.
Okay.
I'll send it out today.
All right. So speaking of CME, today's number is 15227. 15227. I apologize for putting that out last week. I had the wrong number, but I did check this out, and it's today's 15227. And then for the people that were on from Florida, they were at 15225. 15225. All right. So then, how are you doing for time, Mick? Mick Malloy.
Good. Good, Paul.
Yeah, because I'm really looking forward to hearing from you. So that would be really good. David Purse, how are you looking for time?
I'm good, Paul.
All right, excellent. This is like, okay, wow, a miracle has occurred. I'm still paying attention. And then Amal's going to join us later on. He can't get on for about a half an hour or so. All right, anybody else have time constraints? Ken usually do, so what's happening with you?
Yeah, I probably have to leave right around 12 or 12:15.
Well, let's do this though. Let's go ahead and start with you anyways. And Sandy, how about you? Do you have to get off in a half an hour?
I'm fine, Paul.
Okay, good. All right, so that's good. So Ken, why don't you go ahead, since I know you're probably the tightest in terms of time. Why don't you go ahead? Do you want to give us a report either from the state of Florida or anything else you'd like to talk about?
Yeah, sure. So we've been enjoying this COVID lull, and we've used that time to do a number of other initiatives. And I think I mentioned our addiction stabilization unit project that starting to heat up in Florida. We've got a really great best practice that we've looked at in Palm Beach County with their addiction stabilization unit. And now we're looking at ways to propagate that across the state, have folks have a combination of EMS protocols, buprenorphine from EMS. Palm Beach County Fire Rescue has a great program where folks that don't get transported by us but are overdose, our social workers will call them and encourage them to get hooked up with various services. Then we bring them to the emergency department where the folks there are trained to not just let these folks go. The patients can stay as long as they need. They get started on medication. If they have dual diagnosis and need to be admitted for psychiatric reasons, it's a psychiatric facility. They have people working in their ER based on a grant from the Department of Health that are patient care navigators. We call them recovery specialists, or folks that have the same disease who will then, once they're stabilized, walk them over to the co-located medical home, where we've got a board certified psychiatrist, dual board certified in addiction medicine specialties, as well as all the other subspecialties you need to treat hepatitis C, HIV, et cetera. And that program is great. We've got great success, and they do these things called BAM indicators, which that's one of the problems I see with programs out there. They don't measure their success. So these brief addiction measurements, I think is what they're called, BAM indicators. You can get it from SAMHSA. I would encourage anybody to work in that space, make sure that you're having those indicators put on there. So that program we're going to try to do around the state. But the latest thing is our numbers in COVID slowly starting to go back up again. So it does look like this lull that we've enjoyed is going to be coming to an end. It's almost all BA2 subvariant of Omicron here. That doesn't yet mean that we're going to translate into a big issue with hospitalizations. But when you look at the various therapies, we got Paxlovid all over our state and in a lot of the pharmacies. And that's great, but a lot of the people at highest risk can't take Paxlovid because of the medications they're currently on, whether it be blood thinners, antiarrhythmics, et cetera. And I think something that's really underutilized is Evusheld. This is an antibody that's for pre-exposure prophylaxis, and it gives you at least 6 months, maybe as much of a year of protection against COVID. And it works great for anybody in whom the vaccine doesn't work for, which are a lot of those same people you like to give Paxlovid to, but they can't because the drugs are on. So advanced age, undergoing cancer therapy, autoimmune disease, people taking steroids for COPD. So we started a program here, and it's kind of analogous to what we did with our vaccines, where we're going to have folks go to all of our long-term care centers. We're going to send strike teams. We'll schedule it like we scheduled it with vaccines, but then instead of bringing a vaccine, we're going to bring Evusheld, and we'll have those facilities have a list of patients that want to get the Evusheld, and hopefully we'll get as much of this done before the next peak arrives, and we'll be able to protect that vulnerable population. We're doing the same thing in our underserved communities, where we're going into these communities and try to get all those folks that either can't get the vaccine or the vaccine won't work on them, and try to get them some of the Evusheld as well. So I think it's going to be a really good program for the people out there that are still highly vulnerable, even if they have vaccine-induced immunity. We know that vaccines don't work really well in all populations. That's where the Evusheld really comes in. That's all I have, Paul.
All right, Ken. So we've been kind of talking about this the last couple of weeks on this thing about the issues about that we seem to have a lull, but that the numbers are going up. And since we're not seeing hospitalizations, that's kind of a good thing. However, the other issue is that we think that the numbers we are seeing is probably an underestimate of what we're really going on, because either people are self-testing and not reporting it, or they're not that ill, and so they just felt bad for a day or whatever and just let it go at that point in time. So is that your opinion as well?
I think there's no question that the folks that are self-selecting for home tests, et cetera, probably won't end up being in the hospital anyway. So there's a lot of folks that are starting to think that looking at case numbers at this point in the pandemic is probably not as useful as looking at hospitalization data. Because you really that's what you care about. Is it going to affect society, cause the death rate to go up? Is it going to collapse the healthcare system? So I think that's really the more important metric.
The other thing we brought up is the issue of long COVID, that you may not get that sick, but you may. So I have 3 or 4 people I know anecdotally who've called me because they got it. They got kind of the fever, felt rotten for a couple of days, stuffy nose, but then all that went away and kind of thing. But they were left with this kind of very mild but present vertigo that they had, and so. And there's probably other people that have other kind of residual symptomatologies, particularly if it involves nervous system. So,
Paul,
yes.
I think it's important that everybody realize the studies that are coming out of Hong Kong showing that the Omicron, that they are experiencing the same level of severity of cases as with the ancestral strain of SARS-CoV-2. And that is because of what we've said a million times, and that is because we have a high level of immunity, either from vaccines or from prior exposure. When we get hit with a new variant, we don't get to the same level of severity.
Yeah. Okay. Yeah. So either way, though,
and Eileen, I always love hearing from her. So it's not that the variant is inherently less virulent. It's that our
Right.
population has natural infection induced plus vaccine induced immunity, so we have less severity.
Nevertheless, though, just my point that I brought up,
Exactly.
my point that I'm bringing up, are we now going to see more cases, even if they're mild, of long COVID,
So
afterward?
the long COVID, and Eileen knows this, you know this, Paul, and we've mentioned this here before. I apologize, I couldn't be on the heels the last couple of weeks. These monoclonal antibodies, if you are involved in having these things, and I know we've got several out there that are no longer emergency use authorized, please don't throw that stuff away. Not only could this potentially be used in the future if the variant mutates again and becomes active again, but this idea of long COVID, we already have several cases where folks had long COVID for as long as a year and a half that were essentially cured with monoclonal antibodies. So we really need to do a formal study on this, but I do think there's something to this long COVID stuff. In fact, I just had another patient I know of that had long COVID symptoms since Delta, and then got COVID positive again and took the newest monoclonal, the bebtelovimab, also got better, just like because the other case we had from Regeneron. So it looks like there's something like perhaps there's viral persistence or some other mechanism that we don't yet understand. But the bottom line is I think there may be treatment options using these monoclonals for certain patients with monoclonals, not necessarily those that develop lung scarring, et cetera. I won't mix that, but some of these weird metabolic stuff.
Yeah. All right. So, yeah. So, and I think you're going to see more of it, or people with some sort of unusual fatigue syndromes, et cetera, as well. And as was just noted. All right. I don't know if I want to switch gears unless you guys want to bring something up more about it, but we come back to it later. But since I have all these public health people on the computer now, from Eileen and Ken and Libby and David, et cetera. The news came out about the adenovirus causing hepatitis in kids. How severe are the cases? Can you guys answer that for me? Are you seeing that, Ken, in the state of Florida, for example? How severe is it and how widespread is it? And it's interesting because adenovirus usually is a pretty mild thing. You actually see these people are gathering together either as recruits in the Army or getting together. I've seen it on the tours I've been on, where a small gathering of people get together and then all of a sudden everybody gets sick, but they don't get that sick. It's just that it stays on there for 6 weeks. They're still coughing, 6 weeks later. But this is a whole new twist on adenovirus here, causing the hepatitis in kids, from what I understand. So I didn't know if, what you're seeing and what the epidemiology is there and how sick people are getting, Ken. And then I was going to turn it to Eileen and then ask the others as well.
So for the adenovirus one, I think those cases are relatively limited number of cases. I don't know if we have any in Florida yet. I know we were looking into, I'm supposed to get a review, an update on that later from our epidemiologist. I think it was Alabama was where most of these. Maybe Eileen might be more up to date than I am because
Libby says doesn't know of any cases in Hawaii, and and then is this
We've seen it in multiple different parts of Alabama, and of course it's been reported in the UK, but I have not seen any cases in Florida.
Okay, got it. All right, we got 4 cases in Ireland, and Nick, and what can you tell? So big picture wise, it's not a big deal, except it's a new thing and some kids are getting ill from it, and that's important. What can you tell us about the cases in Ireland, Nick?
Not a lot. It came up by accident. I think they were looking at kids in one of the hospitals which has a liver unit, sort of particular focus on looking at liver enzymes. I think in standard, when kids get sick, they may not always send LFTs, they just send the UNEs. This particular place always sends the LFTs, and suddenly it flagged up for them that they got quite a few in a short proximity, and then went to do viral screens, and it turned out to be an adenovirus for all of them.
Yeah.
I don't know, I haven't had any updates on how severe the illness was, but we got alerts a couple of days ago. I can share the alerts with you if you want.
Well, Sandy Schneider, want to tell us a little bit about the CDC's reporting?
I was just trying to look up to see. CDC yesterday sent out a HAN alert, I believe it was, on this. Several hundred. My thought was, I'm trying to find the exact number. It's either 600 or 700 kids that have been reported pretty severe from what it sounds like, at least in some of them. 10 underwent transplant, one just died, and that was set out the alert yesterday. I'll try to find the exact number of cases, but it's in the hundreds, not thousands or millions. It's in the, and it
Still-
seems to be widespread. Eileen, do you have any, I'm sorry, Eileen was shaking her head, so I don't know if she has any more.
No, you know what I know.
Well, the question is, what I'd like to hear, I think we all need to know, is that what's the epidemiology? How do you get it? How do you contract it? Where are they getting it from? And are the age groups infants, or are they young children that are exposed to other children?
Let me look up the alert. I didn't read it in there, I didn't remember reading it in there, but I'll put it in the chat if I come up with something. And I'll put the, whatever I find.
Yeah. David or Libby, have you guys heard of anything, or do you know of anything that we should know about?
So we don't have any cases here in Houston that I'm aware of. My understanding is that the adenovirus link is still theoretical.
Yes.
Right, they're still working with that. It looks like that's guess at this point.
Good point. And thank you for bringing that up. Okay. Because it doesn't seem like it connects to adenovirus very well. So, okay.
Yeah, that's, but they also say that one of the problems in the report that I'm looking at is that, each place does their evaluation a little bit differently. And so you got a lot of places that test the kit for adenovirus, and then a lot of cases that didn't even test it for the adenovirus, right? So we got a lot of discrepancy because these are occurring in multiple countries. And the numbers are still small, but but nothing to report out of Houston at this point. Just what I'm reading from the CDC and an Epi blog that I get.
So what I was trying to bring up is that even though it's a very small number of cases, it's extremely unusual, it's novel, and I'd like to know why this is happening. Is there anything we need to know about to prevent it from being spread further, et cetera? So we'll just have to watch it. So, okay. Anybody else want to add to that before we move on?
Oh, it is not linked to the COVID vaccine.
Okay. Oh yeah, that's right. So, okay.
To be clear, there's been no causation or correlation or anything.
Is it because you're wearing masks and you retain the viruses and you get it from that, right?
And Dave knows that because the tracking devices in the COVID vaccines, you can see where the other cases are. And so there were none in that area.
Yeah. So on my other screen, I'm looking at everyone in Houston is vaccinated and all of their personal information is there, including bank accounts.
Oh my God. Okay.
Oh, crap, this is recorded. I was kidding.
This is for anybody who watches this later on. That was all J-sign joke, right? Okay. Sorry about that. All right. So, any event. So thanks, David. And Libby, anything else you want to add? Well, before I go away, I want to come back to you in a second, David. Libby, anything else you could add to that then? Being another public health person. It's amazing how many state health directors we have on, and then large city medical, large city ID people we have on, and public health officers. But go ahead.
Houston's its state unto itself. Come on.
Okay. Got it. Libby, go ahead.
No, I don't have anything else to add.
Okay.
I don't have anything else to add. Thank you.
All right, good. Hey, so let's see, who was I going to be turning to? Oh, David, do you want to bring up the subject you and I were talking about, just the shortages? You don't have to go into details, but in your area or just across the country, since we got George Hatch on, the shortages of paramedics and the pipeline and things like that. You guys are primarily a firefighter system, so is it a shortage of firefighters as well, or is it, what are you seeing as we go down the line?
Yeah, so because Houston is, we may be a little bit unique, or maybe not. So we've got this huge pay problem here in Houston where it's been going on for years. The firefighters say they aren't getting paid enough. It actually went to a referendum, got voted on by the populace. It passed. They should have got a 30% pay raise. That got appealed by the city. It was overturned. And so what we're having now is we got the usual attrition from people retiring. We're training new folks coming into the fire department, and a big percentage, like maybe a quarter of them, as soon as they graduate, are leaving and going to other departments. So what's happening now is our attrition is exceeding our rate of new firefighters coming into the department. And as a result, there's tons of overtime available because we're short-staffed. And as a result of that, our guys are now, the paramedics in particular, are so exhausted that they're turning down overtime. And we're having a serious paramedic staffing problem. It's our standard here. We've got a tiered system. We've got about a little bit over half of our trucks are BLS and a little bit less than half are ALS. And historically, we've had 2 paramedics on a paramedic truck and on a medic unit. And right now we're going 1 paramedic, 1 EMT, because even with overtime, we can't get them to come in. They're just exhausted. And of course, who wants that job, right? So trying to recruit new people to go to paramedic school is like poking somebody in the eye with a stick.
There's an analogous situation with the nursing situation in that, for example, when people quit their own hospitals to go become a traveler at that hospital so they can get paid more, et cetera. And or they'll leave or go somewhere else altogether, et cetera. So that's compounding the problem of people getting, exhausted with all that. All right. Well, anybody else have any issues? But George, can you give us another confounder on this? George Hatch from COAMPS.
Yeah, thanks, Paul. I mean, I guess, what we're hearing in some circles, and, it starts as a little, and then, maybe there's some smoke there, but we seem to be a popular punching bag for, we're the cause of the workforce shortage. The accreditation of paramedic schools is problematic. I think to what David was talking about a moment ago, I mean, people are exhausted. I know of one initiative, I can't really talk a whole lot about it right now, but they're looking at maybe throwing funds out there to be able to sponsor folks to go to paramedic school, not just paramedic school, but EMT, AEMT, that sort of thing, which I think might bring some folks in that otherwise might decide that they're not going to go because the cost is too high. But I don't think there's one factor. I think it's multifactorial, and school is just one part of that. But people, it's a tough job. It just is.
Yeah. And Meg, you're saying you have the same problem. You don't have a fire department service, you have a third service. So is the same issue showing up there as well? And how so?
Yeah, so I'm the medical director of both New Orleans EMS and the fire department, and we're having similar issues in both departments. At New Orleans EMS, it's been particularly difficult because we've had the hospitals are hiring our paramedics to compensate for the nursing shortage, and so people are leaving for much higher paying jobs. And they've even said, like, if I could afford to stay, I would. But we've got plenty of overtime shifts that are going unfilled. We've been working hard to try to come up with some incentive pay issues. We're looking at starting our own AEMT program and trying to figure out what the barriers are to our current EMTs becoming paramedics. And we're looking at starting some programs like exchange programs where we're going to invite paramedic students from other parts of the country to come and do a rotation with us, just to try to find ways to get more people excited about New Orleans EMS. But, I think we're all experiencing similar staffing challenges, and I don't see it going away anytime soon.
Right. Now, one of the things that comes to mind as we go through this is that it's sort of also what's happening in society as a whole. I just was depending if I talk to someone who runs a restaurant, or if I was at a hotel recently and I was talking to the general manager, and that what they're saying is they can't get people to do certain jobs here and there that they used to be able to get pretty regularly. And I said, so what are they doing? They said the unemployment rate's down to, the lowest it's been in a long time. And they said that, oh, they're doing gigs. And I didn't know what gig work was, but gig work is like if you're doing Uber or if you're doing various things like that. So a lot of people are doing that so they can control their time better. So I don't know if that's a whole philosophical thing that's happened after, after COVID and people rethinking things existentially or whatever, who knows? David Miramanis, you have a comment, I bet.
Yeah, so with COVID, we have, in our department, we've created a monster. So during COVID, we said, if you're sick, stay home, right? So we never had that a sick call issue until we started really pushing this. And our vacations are very regimented in the fire department. I mean, they're select a year in advance. So we had folks trying to use sick time as impromptu vacation time. So we had a lot of problems with sick call. where we had to do mandatory overtime, callbacks or holdovers just to staff the units. And unfortunately, we had to do start a program called convalescent visits. That's where if you called off sick, your BAT chief would call and or visit your residents to make sure you're not in Aruba or something, right? And that has led to some disciplinary action to enforce our HR policy about what sick time is versus vacation time versus PTO time. So we've kind of created a monster when we say, please stay home when you're sick. And now they're saying, well, I'll stay home when I don't want to go to work. And that's been quite an issue for us in the fire department. And, you know, we don't have a problem with people in our pipeline because we pay extremely well. In fact, sorry, David, I stole a bunch of your firefighters this last class. They were in our.
We're wondering who did that, right?
Yeah. They come see us because we have a great retirement benefits and pay. And we actually have a fair amount of overtime available, even in fire. So for them, it's a pretty big gig. What really cooked us also is all these additional programs. COVID, we had, we're staffing testing centers, vaccine centers, all that stuff. And the overtime just got out of hand. Granted, we got, reimbursed for it, but it really took a toll on our folks. And so now that the kids are going out of school, they really want to spend more time with their family, kind of make up for that 2 years of really working too hard than they should have.
Yeah. Hey, let me ask, I want to see everybody else to pipe in here, but before I do that, I'd like to jump up to Canada and see, is this only in our country or what's going on up there relative to you? What kind of systems do you have? Relevant, does that make a difference, by the way, whether it's fire system or other, third party or whatever, or hospital based? Go ahead, Mike.
Yeah, no, thanks, Paul. Yeah, we're having similar problems. I wouldn't say in every province and territory, but it seems to be, similar. Most of the services are not private. There are a few in some of the provinces, and there's sort of one province that has a fire-based system, but otherwise they're usually either provincially run or municipal sort of combinations. But I would say in Ontario right now, it doesn't seem to be too bad, but I know in the sort of the East and the West Coast, they are struggling, very similar to what David's described with regards to numbers and not having the ability to keep recruitment. Some of that's cost related with regards to salaries, etc. There's also been a big exodus of people not going to school. So same sort of thing is that people are not choosing this as a career. And even, as Paul said, nurses are leaving the emergency department because they don't want to work there because there's other opportunities where they may not be as exposed or, is not as stressful. So I think this human resource issue is happening quite a bit.
All right, and then how about Mick? You guys have had the same problems there, right? And in Ireland as well.
When you say the same problems, Paul, which same?
I mean, regarding staffing and not having enough, paramedics or whatever it is that EMS personnel.
The issue was that there was a small number to start with, and then when we went to the what do you call it, COVID sickness, and saying, if you're sick, stay out of work, it really affected the numbers. So there's been a big recruitment campaign. One of the universities has opened up a new paramedic program in the last couple of years. It's now an undergraduate degree program here. It hasn't quite married up to automatic recruitment yet, but we're hoping that's coming over the next couple of years. The Pre-Hospital Care Council, which regulates the paramedics, are trying to push it towards an undergrad degree program, and that may dramatically enhance recruitment for it, and people see it as a career lifestyle choice.
Yeah. Okay, and then before I go over to Fiona, because we got to catch her up around where we are, has anybody, by the way, before Ken had to get off, unfortunately, I hope everybody got to see, thanks to Josh Hartman and company, Ken being on the cover of the EMS World, which is really pretty cool. So it really was great. So let me ask you this: anybody have any solutions to this, or what are you doing about this? Because you're all having this problem. Any suggestions yet, or do we just should we still just say the epidemiology of there's a problem out there? So
Well-
this point in time. Mark?
We're talking about some things. We're having similar issues where we're in the discussion phase right now of doing things like not necessarily staffing truck companies with paramedics. Right now, we staff all of our frontline companies with paramedics. But the other, what I'd be interested to kind of watch for the future, if anybody knows of Adam Grant, he's a Wharton School of Business professor who does a lot of work on the dynamics of work, and has a podcast out called Work Life. And he notes that in this great resignation, a very, very large number of people who left their jobs are now regretting it, because as many of us know, the grass always looks greener elsewhere.
Right.
So you got to wonder if this is a permanent exodus from the field, or if this is something that's temporary. And as people realize that there's not necessarily better places to go, they may end up coming back. So I don't have any way of knowing that right now, but
that's excellent, an excellent insight. Having said that, maybe it'll land somewhere in the middle, who knows, but we still have a problem no matter what. But that's actually a little hopeful. I hope that's the case. And I think that's what's happening. I think this is just a reflection of society as a whole. That's, that we're seeing nowadays, my personal opinion. So anybody else have any? Clayton, go ahead. You have, by the way, I should identify where everybody's from for the audiences that are listening to this. Of course, I think everyone knows Dr. David Pearce from Houston, of course, and San Antonio, David Miramontes, et cetera. Mick from Ireland and specifically the Dublin area. And, just now Mark Gautreaux, who's got San Jose primarily. And so let's move on to Clayton in LA County.
Yeah, thanks, Paul. And I'm busy washing my mobile office right now, so I'm sorry about the background noise. In California, granted, we have a really powerful nursing lobby. I mean, extremely powerful in Sacramento. But that said, some of this, and we have a big fire-based EMS system that's also has powerful labor unions. So the pay is actually really good. So for us, we've actually been encouraging the state to allow our paramedics to be able to be hired because the state has not allowed it. It's actually in the state statute that paramedics cannot work in fixed static locations. There was an exception made during COVID to allow them to do it. And there's some concern on the part of our regulatory bodies that if they allow that to continue in perpetuity, then the hospitals are going to be hiring paramedics instead of nurses. But the problem is we have such a bad nursing shortage right now, and there is no end in sight. With the fire-based EMS systems paying the paramedics pretty well, we think that the risk to us losing employees is very small, because probably it would be a pay cut or at least a lateral to go over to the hospitals. But where it really would help is on the private side, where we have paramedics that are really underpaid. And I got to say, I think that creating that competition a little bit, if the nursing union allows it to ever happen, which they may kill it. But if we're able to do it and create a little competition for some of those paramedics, it actually might give them a real living wage, get them up to a fair level of pay. And maybe, if we can get a fair level of pay, we can get more people to jump in to be paramedics. Right now, the only way you can make a decent living in California as a paramedic is with the fire department. So maybe something like this is a model for the future that we can actually drive more people into the profession. But I understand that California is different than a lot of other states in good ways and bad ways. But I don't necessarily see it as an existential threat to us. I actually see it as a potential labor pool, because otherwise our ERs are going to be perpetually shuttered on diversion and stuff, because there's no way they can get enough nurses to keep their beds open. So end of comment.
Yeah, and then the issue with the nursing shortages and therefore our wall times and all that kind of stuff really has an influence here as well, and so on. And not only and it's going to be a vicious cycle, I think, because the nurses who are there are probably getting even more tired and even helping out rookies. Terry, tell them a little bit about what happened with your daughter, what her experience has been, right? As an example, Terry Valenzuela's daughter is an emergency physician. So go ahead and tell us a little bit about what her recent experience was, Terry.
Sure. Am I coming through? Oh, yeah.
Yeah.
Sure. She works in a couple of big emergency departments around town. And at one, she had 2 nurses on a shift in the emergency department. One was a charge nurse and one was a new grad. And on another occasion, she had to show the new ER nurse how to set up a Pleurovac and where to find the chest tubes. So it's not just bodies.
Yeah. So the point is that that is an anecdote, but it sort of quickly exemplifies, what's happening. So it's multifaceted and complex, and so no easy answers. But that's why I want to see if people start thinking about solutions. Before I go on to Candace, because I do want to put Candace on in a second, I do want to then go over to Jim Augustine, because we were writing up about this, what, a year and a half ago, right? And so I'd like to say, when we had our thing, when we were talking about our various pillars that we were out there, we were going to attack, or the theaters, did we have any solutions, or do we need to revisit that?
Yeah, we have some opportunity to revisit that. So the theaters, the 5th theater was Fill the Gaps. And Paul originally brought it up in the educational world, but now it's across all our personnel, no matter the nature of the department. The fire chiefs and the police chiefs, I've been in their meetings the last couple of weeks, both have short-term, medium-term, and long-term strategies in mind for this. And Mark was talking about short-term, where you're shuffling people and shuffling apparatus to get the most effective use of the people that you have in the very short term. Then we have to go about not stealing each other's people and thinking about the best placement of individuals as short to medium term, and then looking at all of our Explorer programs and how you portray the industry accurately in order to get to long-term gains in people, which is what we are there for. We also have a very important role in filling a foundational role within the healthcare system, because a lot of our members go on to become techs, radiology techs, nurses, PAs, APPs, physicians, and we have another very important role, which is filtering out people who shouldn't be in healthcare. And so other industries recognize the importance of EMS serving as a very foundational group to fill the rest of the healthcare system. Paul, before you leave viruses, I was going to mention something happened and we all lost our internet yesterday in South Florida. Completely lost internet. And I don't know, Paul, where you're sitting today, but internet cable, most of phone, most of texting went down, left many of our dispatch systems in place and some of the phone. It supposedly was a fiber optic cable cut from Orlando to Miami and affecting the west part of the state as well. I was in the middle of delivering a message in a webinar when we got cut off. 5 hours with nothing. I'm just going to warn you all, at any point, something happened, and all of a sudden, all of our digital services were lost. Be aware and be prepared.
Right, and so the backup, I may want to come back to Nick later and talk a bit about what they would advise to us to doing after they have their medical records hacked, that kind of thing. Let's go over to Nick in Minneapolis. And Nick, you have a comment for us?
Yeah, I just wanted to share with this group, we had a state demographer who studies population changes come and speak at our state EMS conference a year or so ago. And I would imagine Minnesota is similar to a lot of the parts of the country. And they said that based on, the baby boomers and people's, expected career lengths, immigration, all those things, that we could expect in Minnesota a workforce shortage across all job classes of, every type, shape, color, and size for the next 50 years before we're going to recover. And so
50? Okay.
Yeah, 50. So my entire career, we can expect that, which tells me that I think, as the physicians, we have an impact in trying to make the places that we work with, the best places to work with, the best protocols, the best practices and procedures. But I think it's still going to be a challenge.
Okay. David? San Antonio? I think you're still muted, David. David Miramanis, or is he frozen or, oh, maybe he's going 1 minute.
There we go. So I think a big lessons that we learned is don't stop training during a pandemic. So we had to figure out different ways how to train our folks, both initial education, continuing education, all that stuff. But I think a big lesson we learned over the 2 years is if you stop training, you're going to be 2 years behind. So we didn't. We were very aggressive about continuing both initial ed, continuing ed training, body lab, everything with masking and precautions and all that kind of stuff. But I think that's a big takeaway is don't stop training and continue all the things you normally do with safety in mind, but don't stop. Do workarounds, do virtual, do small group simulations instead of big classroom activities. Just don't stop training.
All right. Well, I want to sort of quickly switch gears because this has been actually a good discussion. It's very reminiscent of Eagle Creek, right? Feels good. Thank you guys for all contributing here and piping in. Anybody else want to make a comment on that before I switch over to Candace? If not, Candace, are you there today? Did we lose her? Huh. Okay, that's too bad because we did need to talk a little bit with her. So she's probably going to get on with me later on. But I have had several people call me this past week. David, you want to lower your hand, by the way? So I've had several people call me this week saying, "Are we get invited to Eagles and all that?" So that's been a concern to me. If anybody on this call hasn't gotten an invite, let us know. And Candace supposedly has set out, or it did set out, but hopefully it landed with you, invitations, etc. But I've got to know the hotel count by the end of this week. So anybody who hasn't signed up, let us know. It's kind of urgent because I got to make sure there's only going to be a limited number of rooms at the place where we're staying. That's all. Candace, do you want to pipe in and tell us, where we are at this point in time? Are you, Candace?
Sure. Yep, I'm here. So,
Okay,
hi. So we have around 35 of the team members registered for Eagles Creek, which will also automatically give you registration to the Eagles main conference. That equates almost equally to rooms. I'm going to post my information in the chat again. And if you need any support on registration, the links, etc., call, text, email me. I know I have probably 2 or 3 emails pending that I will get back to you today. In addition, just to be clear, when you click that link for the hotel registration, you're just providing some of your information. Our conference coordinator will send you your final hotel confirmation and registration. That's all being taken care of for you. So if you need anything additional beyond that, just call or text me.
Okay. Anybody not heard from her or not had an invitation that's on with us today? All right. And we're going to go through the list.
Sorry, Paul, it's Glenn. I'm sure it's in my email somewhere, but I cannot find it. I'm just going to send her an email right now. Thank you.
Yes, please.
All right, good. Because I know a lot of people are planning on coming and they said, when are you going to invite us or when do we know about hotels? And I'm going, we should have known some time ago. So just so you're aware.
Luckily, there's a nice solid block. I think we have around 75 to 80 rooms. And if we need more, we still have the Hard Rock and we still can make room.
And a couple of people, contacted me. They said they are bringing their fellows, and they're going to be paid for, and they're going to pay for registration for Eagles itself. Okay. But we do, but their request was, can they stay at the same hotel with us and attend Eagle Creek? And the answer is absolutely yes. Particularly if they're, what's the word I'm looking for? If they're, paying for themselves and paying the tuition for the Eagles, out of their allotments or whatever, that's fantastic. But we'll try to get them plugged in the same hotel with us so they can attend Eagle Creek gratis, with us and hang in with us. All right. So is that correct?
Yes. And just one last thing on that list of things to do, there was a questionnaire of when you're coming, if you'll be attending the cadaver lab. So just so you're aware, for anybody that's bringing fellows or residents, there's a cadaver lab available Monday, which is a day of arrival. There's also a second cadaver lab.
Before you go on, and it's going to be located at our hotel where we're staying, correct?
Yes. So the cadaver lab is at the Le Meridian Hotel, which is where we'll be staying. So it's available Monday on your arrival day. It's also available Wednesday, which is, Thursday. They will be having a very specific medical interventions Thursday afternoon. I know that's during Eagle's main conference, but there's availability to bus over to the Le Meridian for about an hour, hour and a half time for central lines, airway, vascular access. So you'll be getting an additional invite for that for any fellows and residents.
Yeah, and they're generally, those have been targeted mostly by some, I think, companies that are showing some of their products, and they're, just so everybody's aware of that, I want to make sure everybody is. And it may be things that fellows are already been doing, but they may want to learn more. That could be an interesting thing then for them as well to add to it, in case they come in early on Monday, or they're there all throughout the day on Monday the 13th. Okay.
Just one last thing about the hotel. The rate is $189 per night plus taxes. There's not really a lot of fees. So I think that makes it around $205, $210 with all taxes included. It's free parking and they do have free breakfast. You'll see a lot of nice perks. There's a really nice tequila bar and Mexican fusion restaurant in there as well.
I don't think that would interest anybody in our group. So, okay, good. That sounds fantastic. Thanks. If you can hang it down, you and I really do need to talk. So can we get together right after this or 2 o'clock your time? I don't know what's best for you because I have to go to the airport. I'm going to Fort Lauderdale tonight. Okay. So, and if you have time, we'll continue this tomorrow as well. All right.
It'll be a long way for me, but you know how to get a hold of me.
Yeah, I'm going to come get you. So, all right. So let's see. Let's go ahead and at this point in time, and by the way, now that we brought that up, I think that if there's any topics you guys want to talk about, let me know up front. I can schedule for Eagle Creek, or I can just do it in the usual manner we've done before. Please be thinking about 3 bulleted talks that you can give, me that I could choose from. To see the meeting, if I can mix and match with other things and themes. Like I've already heard some kind of cool themes that are coming up already in different arenas. And so I think we're going to definitely be putting them on and, give some perspectives, from various sides of the fence. So I think it's going to be kind of fun. Terry and Ray, are you in the position to tell us, or do you want to surprise us with what you're going to debate at the meeting?
Terry, you take it away, Terry.
Okay.
You're being too polite, Ray.
We want to surprise you.
That's because once I destroy him, I want to still be friends.
Okay, got it. All right, good.
Big
All right,
topic.
and you guys will want to do it on Friday afternoon like you usually do, is like a good, as a good, what do you call it, build up?
Paul, I think I'm traveling back on Friday. Is it a possibility of doing it earlier?
Sure, we can do it earlier. So just let me know what your travel schedule is. Okay, it'll be great. We're looking forward to it as usual, that kind of thing. And as the insults are thrown back and forth, but just.
I think we picked a topic. You want to quickly mention or no?
He said not. He wants to surprise you.
All right, surprise it is.
Yeah. All right, thanks, Ray.
I'll be using my computer. He'll be using an abacus.
Okay. I'm looking forward to the abacus. That'll be great. So, all right, let's go over to Fiona, if you're still there, Fiona, and see what's happening in UK. What's the latest report over there? I hope I didn't lose her. So Fiona, you're there.
Thanks. Good afternoon, Paul. Good afternoon, everybody.
You look very official today. I love it.
Well, we've got some problems back at the mill. I'm acting chief executive again. Chief executive sick, so I'm not sure whether that's going to impact on coming to Fort Lauderdale, but we'll have to see.
Okay.
From a COVID point of view, things are more positive. The testing regime has gone out the window, so we've got no real idea of how many cases there are out there. The prevalence is still very high. The number of hospital admissions is gradually going down, and the number of patients in ITU beds is stable and not causing concern. I think the concerns are rolling out the vaccine to the under 75s. We've been doing the over 75s, but clearly a 4th vaccine is coming our way. Highest numbers are still in children. One other thing to flag, I'm not sure whether you've had any cases in the States, but we've now had 114 cases of hepatitis in children under the age of 10, mostly under the age of 5. And of that 114, 10 have required transplants. Nobody's died yet. And it's currently being put down to an adenovirus.
Yeah, and we brought that up. We had a discussion about it earlier today, and there is some question being thrown: is it really an adenovirus or not? Because it doesn't. That's not typical of an adenovirus, not in the past at all. I remember being in London, of all things, down at Twickenham, and having a couple of my people on the U2 crew having a constant cough for 6 weeks, but they were not ill, and that's the classic stuff that you'll see, and then. People don't even go see doctors about it or get tested for it. So it's really unusual for adenovirus to do this. So we're wondering if it's either a surrogate for something else, that's going on. That's what I'm saying. We want to know what the epidemiology. What do we know anything about how these kids got exposed or what caused it? Is it? We presume it's contagious, right? So that so many people got. So that's going to be interesting. So give us a follow up on that. We're going to be really interested in hearing. Is there something we need to be doing epidemiologically or interventionally to prevent spread here, and so on. I'm sorry to hear all those cases. But anyway, all right, well, thanks. Anything else? How are you doing? Okay, yourself?
Yeah, I'm very good, thank you. The other thing, I guess, is you were talking about staffing. We are also having difficulties with staffing. Our staff sickness levels have come down a bit, but there's still confusion around how we manage people with long COVID and whether they're managed under the normal sickness regime, which would mean that they'd be managed under capability if they were off sick for. I mean, we've got some people who've been off now for 2 years.
Yes.
And we're not able to manage them under the normal sickness process. So, and in terms of recruiting people, yeah, we're recruiting as fast as we can. Our people coming currently through the undergraduate route, and the limiting factor is the placements, both in hospital, in primary care, and on ambulances. And that's what limits us for the ambulance service. And we lose paramedics to primary care. There is a specific scheme attracting paramedics into primary care to work in general practice, often doing home visiting for GPs or just running clinics for GPs. And that's in the warm, out of the rain, and social as opposed to unsocial hours.
Does it pay more? Is that what makes it attractive, or is it other issues?
At the moment it can pay more. It's paid at the same rate as our specialist paramedics. And although it should only be attracting in specialist paramedics, some of the GP surgeries are looking for paramedics who are leaving university, so are absolutely zero experience.
Okay, got it. All righty. Well, I'm just so sorry the continuous problems that you're having over there under those, in those situations. So, all right. So let's do this. Hey, I just want to say, Amal, you have anything to report on for us? Or anything? I mean, it doesn't have to be about cardiological, but it could also be general medical stuff that you have for us. Welcome to the show, Amal.
Oh, thanks. Sorry, I'm joining late.
Yeah.
I don't have anything specific. I think there have been some interesting things that have been reported recently with regards to myocarditis that I'm going to be looking through for some lectures, and I might be able to get back to you next week if there's anything new about that.
And you've been part of the team. I hope that you can be making it down to Fort Lauderdale with us, and we'll put you on. If you can give us maybe that's a good one to report on. That kind of thing. Give it an update. So that'd be cool. Good. So, all right. And how's that looking? Does it look like you'll be able to come to it?
I don't know yet, because I know our kids' high school graduation and the residency graduation are around that time.
Yeah.
But
for the first couple of days, let's say, if it's, that would be really fantastic to have you, join us. We all love having you with us. Okay. So
thanks. I'll definitely do my best.
All right, good. So, all right. And then let's see what else I wanted to ask about, or who I wanted to ask some specific things about. All right, let's do this. I'll start making some rounds on some people we hadn't heard about. Jim, anything you need to report on from IAFC or IAFF that we should know about? And I did get the invitation with Meg to come up to Chantilly, just so you know. Okay.
Good. Thank you. Nothing else to report, Paul. Thank you.
Okay, good. Doug Kupis, anything you can tell us about on the various areas that you represent? Hope I'm not catching you off guard, Doug.
Hey, Paul. No,
yeah.
just slowing down the treadmill. Hey, Couple things. Well, actually, really one thing I'll report on. Before the infrastructure bill passed, the Department of Transportation had put together sort of a about what it would take to get to 0 fatalities on our nation's highways. And the intent was to have sort of a, sort of start the process of what it would look like when the infrastructure bill passes. And now that it's passed, that work group's continuing to meet. We're meeting again tomorrow. Much of it is obviously about things that you would think about, like how you can design and build and engineer safer highways, automobile safety things that would lead to less crashes, that sort of thing. But I think the message that I and NAEMT has had with this is that, the other part of getting to 0 fatalities is that there are still going to be crashes and there are still going to be injured people. And, we hopefully have an opportunity to put some of the emphasis out of this, not just into those engineering things, but into an EMS system that is better prepared to ensure that we have 0 preventable or 0 preventable fatalities. So that group is continuing to meet. There is some of that funding that will, I think, lead to some EMS things, and hopeful of that.
Okay, thanks, Doug. And anything new to report from the state of Pennsylvania, since that's your jurisdiction as well?
Not a whole lot. I think Crawford in the past, week talked about the very short-lived, and I don't know if he's on today. I talked about the very short-lived mask mandate in Philadelphia. Otherwise things are, we're sort of in the same boat of many, cautiously optimistic that numbers are looking okay, but still seeing some little bit of an uptick here and there.
Yep. Okay, got it. So let's see if there's somebody else I wanted to talk to along those lines. Oh, well, first of all, let me go to Crawford then in Philadelphia. Anything you need to tell us or add on to comments we just heard?
Paul, can I kick in real quick just for a second?
Who's this, John Kramer? No, you're no longer part of our group. No, just kidding, John. Go ahead.
Yeah,
Sure.
I know. Thanks. I just wanted to follow up on Doug's comment. The National Roadway Safety Strategy that DOT put out a couple of months ago, the 5th pillar of that is actually post-crash care. So it definitely falls under the EMS rubric. There was a Federal Register notice that was put out a little over a week ago, looking at or defining how states could apply for part of the grant money that will be available. Most of it will be focused through the state highway safety offices, but the state EMS offices should engage with their highway safety office on those available funds.
Okay.
The whole process sort of reminds me a bit of the IOM report from a few years ago when it was looking at civilian and military trauma systems and how we could learn from each other, et cetera. But, the goal was sort of the 0 preventable mortality from trauma. And I think, they've seemed to be carrying the same mantra of, 0 deaths on the highways, which hopefully it leads to some good things like the other one did.
Oh yeah, I mean the thing that's interesting about that is the United States has picked up on that several years after a number of European countries have also been working on that same goal. So it's fairly well distributed.
Okay, doke. Anybody have any questions or responses to that or comments? I'm not sure if I've seen the comments here. Those are out here. Okay, well, good. So let's do this. I guess what we'll do is we'll go up 95 to New York City and anything we need to hear about. Thanks for the report last week on the subway shooting, Glenn. Anything else you need to tell us about today?
No, hi, everybody. No, I think, we had another shooting in the subway yesterday, one fatality, but that was just a garden variety shooting, unfortunately. People were running all over the place, but it was somebody probably known to the victim. The perp is still on the loose, apparently, as of this morning. But Other than that, we're still plugging away here. I know that trauma and shootings are up all over in the United States, unfortunately, like us. But
Yeah, and Candace, I think you just attended trauma conference. Was that part of the discussions, or people seeing an increase? I mean, you're seeing an increase in penetrating trauma at your own hospital, right? I don't know if you're still there, Candace, or not. I'm sorry if I blindsided you. Probably did. She's probably busy doing some other things. But yes, I think we've all kind of seen an increase of violence going on. And are aggravated assaults up there as well, Glenn?
yeah, unfortunately, everything is up.
Including domestic violence and all that kind of stuff. So, all right. So I think it's not total news. It's just a shame. That's all I can say. All righty.
And unfortunately, we had a firefighter death yesterday at a fire. So on Sunday, I should say, but
yeah,
getting prepared
okay.
for the funeral and such, man.
I'm sorry to hear that as well.
Thank
Okay.
you.
Well, Joe Holly, I haven't talked to you for a while. I mean, you've been on, but I haven't tapped you tonight. So I thought it's about time for me to catch up with you, right? How's things in Memphis? What's going on, or anything you can report to us?
Well, good morning, everyone. COVID-wise,
You're kind of breaking up, Joe. I'm sorry. So maybe a connection issue. Is it me or him? Is there a connection issue, Jim? Oh, just lost you
Him,
too.
Paul.
Huh?
It's him. It's Mick. It's him, Paul. I can't get it either. I'm getting you perfectly.
Yeah. Oh, you're fine.
Okay, good. Okay, sorry about that. Hey, Joe, we lost you. So, or do you want to get
Are you
to
there, Paul?
Yes, I'm here now. Yes.
Okay, sorry about that. I'm changing my connection setting there. So a small uptick in COVID stuff, not terribly impactful. Same shortages in both medications and personnel that everyone else has discussed already. We did have one of our hospital systems, which is 2 hospitals here in my area, hit with a ransomware attack, which took all their computer systems offline, and they have been on paper charts, et cetera, for about 10 or 12 days now. That situation is still not yet resolved, and I think it actually was not directed at those 2 hospitals, but at the corporate structure. So multiple hospitals in other states in that system affected as well.
Okay, got it. So that's interesting thing. And I guess I should jump then over to Nick Malloy, since they suffered with that for a long time, back, what was it, last June or whatever it was. And so, Mick, what are the lessons learned? What advice can you give us? We're going to anticipate, especially with Russian hackers, that this is going to happen more and more, because that's what happened with you guys, those Russian hackers. So tell us a little bit about what you suggest for us we should do to prepare for that.
Change all your system to max.
Okay, seriously? And
Seriously.
why? Yeah, why is that? Why would that be?
Because the viral loads they're using don't work on BSD Unix systems. They're working on Windows exploits. That's the problem. So our systems have been fixed. We did lose data. We now have had to upgrade a lot of systems from specific types of Windows products up to Windows 10 and beyond. And some are using different interfaces now. Some are using the, oh God, I can't even think of the name of it, but some of the IT systems are using a different software product or different operating system. But what's happening now is the IT professionals keep sending out emails to us all, which are spoof emails, as if it's coming from the IT department, but it's a false email address. And they give you a link to click in it. And when somebody clicks the link, they then send you a message going, we did this as a test. You're an idiot. Stop clicking this kind of stuff and delete these emails when they come in. So that's kind of helping to stop people from clicking on the mails as you go through. I was very interested in Glenn's comment there about the shooting in New York, and that it was somebody known to the police. That's a phrase that's used a lot of the time here. And I had to go and get a passport recently, and the police said they couldn't help because I wasn't known to them. And I said, surely that's a good thing that I'm not known to you, because you always put that on the news when it's a bad guy. But they didn't seem to take that form of humor very well.
So So I'm fascinated then about this issue about the Mac versus the Windows based platform. So that's all news to me and very, very interesting. So I appreciate you letting us know about that.
From a
So
viral perspective, Paul, that they're completely different. The operating system, now it's not to say there's no Macs, no viruses on the Macs and no hardware intrusions, but it is a lot more difficult. It's based on a completely different operating system. It is an open source thing, but it's been open source for 50 years, and there's not a lot of hard crashes been forced through those systems. It's much more stable.
that's interesting. So but I would still think that someone was going to figure out a way to get through that system too sometime. But you're just saying there's been a lot of history here and it hasn't happened. Is that you're saying, correct?
Or to a minimal degree. They have these conferences year on year for hackers. The most recent one, they award 50 grand if you can hack into a system live in front of the audience. And they very rarely get any critical systems in Mac that they can what do you call it? That they can hack into systems to give that kind of access. Very, very rarely.
Well, interesting. Okay. Well, that's all news to me, and that's an interesting perspective. So thanks a lot for the heads up. And any other generic thing, let's say someone's not going to change over the system, they got Windows, if there are other kind of issues that we should do to prepare better?
And again, it's back down to
paper records, or EMS have paper records ready, right?
Well, yeah, that's the sad part. But the what we're trying to be doing here is using ID badges, the QR, the codes, barcodes for logins, to stop people having to do stupid things like writing their passwords down and leaving it for somebody else to find out. So that you're logging in and logging out very quickly on the machine. You scan the barcode, and then the next person comes along, and immediately you're logged out, they're logged in. It's silly things like that, leaving machines open and unmonitored.
Okay. Got it. Interesting then. All right, then let's see if we can move on to a couple of other folks I wanted to talk to today. We hadn't seen. Well, first of all, let me jump over to Milwaukee. Anything new to report there, Ben? We've been keeping up with you pretty well.
Yeah, I don't think anything new this week that I can think of, Paul.
All right, good. And you're working on some topics for me, right, as well?
I am, absolutely.
Fantastic. Angus, let's talk a little bit about how soon would people like to come into the meeting if we have the Florida group join us in our discussions? Is on that, say, Wednesday afternoon, is that what you had in mind, or Tuesday afternoon? What were you thinking? Because you want me to sort of get the word out for that, correct?
Yeah, we have a meeting of the Florida Association of EMS Medical Directors tomorrow. And so I wanted to check with you what time you thought it would be good for them to be there. I want to message them so we get as good recruitment as possible.
Yeah. So here's the deal. What time were you thinking about? Does Wednesday afternoon work for you? And because you guys are having your meeting the next day?
Yeah, that's correct. So that afternoon is probably the best for us. Our meeting for the doctor group isn't until the next morning. So that would probably work the best. And, I don't know whether, the whole afternoon or 3 o'clock or whatever you think would probably be good.
Okay. I mean, we could probably even, the other suggestion, I'm pretty open to it. I think that our group wouldn't have any problem having people in there. I mean, yes, understanding the meeting is primarily for us, but we're not exclusionary, and so it'd be great if they want to come for the afternoon. So what suggestion would you have? What would you like if you had your way, if you could attend?
Yeah,
right?
I'd like to be able to say at 1 o'clock on, because there's a medical care committee meeting that goes until lunch. So if they could join us after lunch on Wednesday, that I think that would be ideal.
And it is, as long as if there's that understanding, and we don't mean to be rude because it's primarily our meeting, is that we'll have our own group that they don't mind sitting in the peanut gallery to make sure at least we have priority seating for the main Eagles, right? So
yeah, absolutely, it'll be an opportunity to come and observe.
We need to have some numbers because Candace is probably going to have to arrange that we have enough seating in there as well. Hey, Candace, are you still on with us or not? Did you hear what we're talking about here? I think you kind of knew about this, but I just wanted to give you a heads up on it too. And
well, I can have them I can have them RSVP through our state physician, EMS physicians messaging board.
Yeah, I don't think it should be a problem, but I'll try to remember to talk to her about that this afternoon. So let's just say after 1 o'clock is fine. They come in as long as they understand to, give priority seating to the Eagles who are the primary, And the other thing is they won't be just sitting in the background. I think if it's appropriate, I'll try to take, comments from them as well and make sure it's interactive for them and even ask them what are the issues they're dealing with, there. So I'll try to, as long as we respect the priority seating for the Eagles, I don't think there should be a problem there at all. So does that sound good?
Sounds great. Thanks.
Okay.
Could I ask one or two other questions from the collective wisdom here?
You can, or whatever it is, right? Okay, go ahead.
So I know a lot of us do pit crew for cardiac arrest. I'm wondering if anybody has done pit crew for STEMI or stroke.
Yes.
So would they be willing to share?
Yeah. So the immediately comes to mind is that Joe Holly did some great work on that. And I don't know if you modified it at all, Joe, early on, or because you're able to document how you did so well with that. Joe, do you have anything you can comment about?
Yeah, I'd say we're quote unquote still doing it, although our compliance is down just due to all the things we've been talking about for the last 2 years. But I'm happy to share some of our pearls if that would be helpful.
Yeah.
Yeah, Joe, if you wouldn't mind just emailing me the protocol to benchmark, that would be awesome.
So about 10 years ago, it was kind of a cool thing because it's classic for Eagles. And just so, I got to bring on the horn now. A classic thing is that we always make sure if you're giving your talk, you have your title slide. The second slide should say, here are 2 questions I'm going to address, so you're reporting maybe that you gave your, basic EMTs Narcan. And so the question would be, are they able to do it? And 2, was it safe? Was there a problem? So and everybody's going to want to know the answer to that. So they'll listen to you and you give the answer at 5 minutes or less, et cetera. So that's the general thing. So what was kind of cool is that Joe did a story where he said, if we were trying to get from one point to the next point, that we get to, let's say get to cath from the EKG within 90 minutes was the classic thing at the time when they were doing their study. He wanted to see it, and he was able to get their times down to 38 minutes from the time the EKG encountered, the paramedics encountered to whatever. And then the next question was, I asked Ray Fowler, I said, well, does this affect mortality? He showed that it did, affect mortality. So Ray has some experience with that as well. And so just into that. And I think others here do as well. So what we could do is maybe have Jim survey the group and say, does anybody have any, protocols that they can pass on, on STEMI. On stroke, there's several other people have had stroke pit crew approach as well. Anybody here on the line? Mark, did you want to ask a question or say something?
No, actually, what I can do is, since you're going to have Jim put out the survey, I'll answer to that. But when I was in Worcester some years ago, we developed a STEMI program that had the interventional cardiologists gain confidence in the paramedics' ability to interpret ECGs. And we tuned the process to where a paramedic would obtain a 12-lead ECG and would notify dispatch, and dispatch would activate the cath lab from dispatch. It didn't even involve the emergency department. So we had cath lab times of about 6 minutes on a routine basis, which is how long it took to get into the elevator and up to the second floor.
Yeah, exactly.
Very cool.
And then David Miramanes, you did a lot of stuff, but it was a little bit different on how to approach the strokes, right? Do you want to tell them a little bit about what your policy was and how your pit career approach for strokes went? I don't know if David's still here. He's coming. I still microphone issue, David.
There we go. So with us, we did a combination of things. We have stroke screening and dispatch. So that activated a stroke alert for the responding crews. So their eyes are on the game and they're looking through the stroke lens when they get there. Then we have a stroke alert, which is by Stratified criteria, your typical stuff. If it's less than 6 hours, and if they're band positive, that is an LVO stroke alert. That's what we're doing now. We expanded the LVO stroke alert up to 24 hours now. And with that, they will transport primarily to the comprehensives, and hopefully later this fall, the thrombectomy capable places. So with stroke, we have that dual non-LVO stroke alert and LVO stroke alert up to 24 hours.
Yeah, so what you'll hear is, I just want to say that it also encompasses, the pit crew is also encompassing some of the connections and the communications ahead of time to even focus it a little bit better. So it's beyond just arriving and then this person handles the blood pressure, this person, does the glucose or whatever it might be. But all those things will, and we have other players that have some protocols that are pretty fast as well. But I just want to make sure I also enshrouded that in the fact that there's more to it than just what you do on the scene right there, et cetera.
So interesting, Paul, one of the things that we found out that was a big driver of on-scene times was the stupid stretcher. So if they know it's a stroke going in by dispatch, or if the engine says it's a stroke, your first action is to bring the stretcher to the patient. Not all the ALS stuff, bring the stretcher to the patient.
What if you thought it was a gunshot? Would you bring the stretcher in?
Well, it's the same thing, right?
That's what I'm getting at. That's why I'm making,
We
Okay.
treat it like a gunshot. Exactly.
Sideways, yeah. Okay, good. So Angus, this at least get you a head start, anything from what you wanted?
Yeah, perfect. Thanks. I'm just trying to put together some sample ones for the state.
What I will do for you is that I think long time ago, and I have to give a pat in the back to Terry Valenzuela because he picked up on it early, but I think back in the 2000s, or as early as that, we were, I had written a paper about how there's a, like when you go to a fire response, you have the plugman, the first linesman, and so on. And we had the same thing. We had an AB guy, airway breathing guy. We had a C guy. And so there was a kind of a pit crew approach that was generic for everything going in. And I remember Terry picking up on that, how important it was. And I really was flattered by that. And early on, so I can even send you, I probably have some data or something I've written up on that. And that might be a good thing to do, because also fire crews really relate to that well, because you say it's the fire, so this is the medical first attack. So that's is one, and I've used it with other organizations as well, and it goes over really well. So we'll talk about that later. Angus, though, let's see. What I'm going to do is, you were asking about some other situation, and I'm going to be on the phone with that person this afternoon. Are you available? I could do a three-way.
Yeah, probably after 3:30 or so.
Okay, after 3:30, I'll not be. I have to go to the airport around about 2 o'clock your time, so it should be okay. I should be able to call you before I get on the plane. Okay, good.
Great. Thanks.
I'll catch you tomorrow. But I hope this helps you then. All right.
It does. Thanks, Paul.
Any other questions you had? I thought you said 2 things that you had. Maybe we did cover them all.
Well, I have a bunch, but I'll save one for next week.
All right. Good plan. Okay, good. All righty. Hey, Stein, anything to report from Colorado Springs?
Yeah, sorry, my video isn't working very well right now with my connection. Nothing much to report from Colorado Springs. We're pretty much dead with COVID. I think Denver area is too. And we're dealing with the same paramedic shortage that everybody else is dealing with. Thankfully, we just launched a pretty robust tiered response model that allows for EMTs to be staffing a lot of our apparatuses. And so that is going to take the load off of the paramedics. And that's about all I have.
All right, good. And then how's things working out with the website, by the way?
The website is definitely coming along, and it should actually be able to go live within a week.
Okay, got it.
Yep.
All right, sounds good. And I'm anxious to see that. And maybe we'll talk a little bit about more of that. If you can catch me, we can do some review of that. All right.
Yeah, I'm definitely gonna catch you before we put it live so that you can review it.
Also, I need to know if I need to send you some remuneration as well. So talk about that with me as well. So call me, okay? Meg Marino, you've worked down in the New Orleans area, if I remember correctly. Anything you could tell us about that?
Well, here we're doing great. We're gearing up for festival season. So we had French Quarter Fest this last weekend and Jazz Fest coming up the next 2 weekends. So we're getting ready or bracing ourselves for a deluge of tourists to descend upon the city, but otherwise we're doing well. We're everybody's in good spirits, and we've been doing great. So can't complain, and we're looking forward to hosting SAEM in just a couple of weeks. So I hope to
That's what I was
see
saying. I was gonna say
some
there-
of you here.
I was gonna say there are some academic tourists coming the week of May, 9th, 10th, 11th and all that. So, yeah. So,
Yeah, so we look forward to seeing you then.
yep. Okay, good. All right. Well, good to hear you, and you're doing well, I assume, right? So, which is good.
Yes. Yes,
All
thank
righty.
you.
Libby Char, anything else to report out there from the state of Hawaii?
No, not really. Same as everybody else. We're seeing our case counts go up a little bit and our percent test positivity go up. We finished our transition plan to go from emergency response to COVID to sort of having to live with it and deal with it. Trying to transition testing and vaccination and stuff back over to the healthcare community.
Yeah. Hey, so since I see you on there, Mark Eckstein, I know, and we don't have, Steve on the phone, but anything you can report to us out of Los Angeles, since that was your old jurisdiction that you had. Mark, are you there, Mark Eckstein? Maybe not. Maybe he's on another call. Here
Oh,
we
hey,
go.
Paul, sorry about that. Yeah, hey, good afternoon or good morning, everyone.
Yeah,
I'm
no,
sorry,
I was just asking, since Steve wasn't on today, I just know if there's anything we need to know about out of LA. I mean, Clayton's filled this in a little bit from the county, but anything that you could report on, and how's your projects going?
Yeah, it's coming along. Knock on wood, COVID's been in the rearview mirror. Hopefully it stays that way. Our project, we're getting traction. We're operational now in Florida, Texas. We're going live in a few counties in California next month.
Good.
Probably the most compelling aspect of our project is the social worker. So anyone who is dispositioned as a treatment in place has a social worker follow-up, and we have social workers who navigate the patient to primary care, getting on Medicaid, mental health, all social services based on the zip code where the patient resides. And the feedback has been phenomenal. That's been a big missing link in EMS. It was something I was unable to get funding for during my 26 years in LA. It was a need for social workers, and that is clearly the secret sauce.
Okay, cool. All right, good. All right, let's see if there's anybody from our regular group that have left out here. It looks like pretty much anybody else want to pipe in and say anything here while I got you. Thanks, Mark, by the way. Anybody else here have
Yeah,
anything?
Paul, I was going to ask Mark, is there any role for your project, for example, to do test and treat? With the new federal guidelines, Paxlovid is an extremely effective medication for COVID and has been proven to really help out with the outcomes. So is there a role for telemedicine where someone could show you a positive COVID test, and then you're able to interview them, do the med reconciliation, and order Paxlovid?
The answer is yes. So we basically have probably the best way to think of it, Dave, is we have a virtual ER in each state we're operational, including Texas. So they're all state licensed, board certified ER docs. So we could easily provide that service.
Okay. Does that answer your question then, David?
Sure does. And it seems like a great way to do some of the folks that are not traditionally able to get to an urgent care and ER because of transportation or finances.
Yeah. All righty. Let's see. Yeah, go ahead.
This is Stein. Mark, I have a question. How long does it take you to get up and running in a state?
Hey, Stein. Yeah, as you know, we're working with a few agencies in your area. So once we have a confirmation, we could go live. It depends on if the software integrations with EPCR and everything else. Probably the fastest we could do in a state is probably 90 days.
Okay, thank you.
Of course.
All right. Let's see. Anybody else want to throw any? It's 12 o'clock here in Central Time and 1 o'clock on the East. So time for me to wrap it up. Anybody else have any other final comments then? If not, we'll just welcome back my friends to the show that never ends next Tuesday. And one thing is I'll probably be reporting in, I think I just realized I may have a problem. I may be calling in from an airport in London. I hope so. Otherwise, I may talk to someone to take over from me. We'll have to see how that goes. So with that, I'll say goodbye to everybody and hopefully talk to Candace here in just a few minutes. So, all right. Thank you so much, everyone. Okay.
Thanks, Paul.
See you next week.